This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar. This seminar.
Good afternoon, everyone, and thank you for joining us today for our HealthyU webinar on surprising risk factors for heart disease. At any time during the presentation, you could enter any questions you have using the Q&A feature located at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presenter is cardiologist Dr. David Shanuda. Dr. Shanuda practices with Three Village Cardiology, a practice of Harborview Medical Services. His practice includes diagnosing and medically treating heart disease, as well as preventing further heart-related events. Dr. Shanuda received his Doctor of Osteopathic Medicine degree from the University of Medicine and Dentistry of New Jersey. He completed an internship at Good Samaritan Hospital Medical Center in Arizona and an internal medicine residency and cardiovascular medicine fellowship at Winthrop University Hospital. He is board certified in internal medicine and cardiovascular disease. Dr. Shanuda.
So thanks for having me. Really appreciate the fact that Mather does these healthy webinars on a regular basis. I think it's a great way of reaching out to the community and describing things that we deal with on a daily basis here at the hospital that impact patients' lives. As a non-invasive cardiologist, my main focus is to do things that are non-invasive. So I don't do stents, I don't do bypass surgery, I don't do pacemakers or defibrillators or anything of that sort. What I do is I treat patients with medications to optimize their health. But what I mainly try and do is to reduce their chances of having these problems to begin with. So, prevention is so key to what we do in cardiology. And that stems from recognizing the major risk factors for heart disease, as well as things that are not so major. So today we're going to talk about surprising, or I should say uncommon risk factors for heart disease. So we'll go ahead with the next slide. And we'll first talk about what is heart disease. And Stu, you can feel free to clip forward as we go along, because a lot of this is perfect. So heart disease can be congenital heart disease, which means you're born with it. It's a structural or anatomic problem with the heart. Heart disease can be arrhythmias, where the heart rate and the electrical problems of the heart are either too fast or too slow, and it's an electrical problem. Then you have cardiomyopathy, which is primarily a problem with the heart muscle itself. It doesn't have to do with plumbing or electric, it's the muscle. The actual structure of the heart is not working properly and the heart muscle fails. That's either primary or secondary. Primary meaning that the heart muscle intrinsically has a problem with it, and secondary meaning that something else has happened to the heart. And then there's coronary atherosclerosis, which is the plumbing of the heart. And that's usually what we talk about when we talk about heart disease. So you can keep going. So what is heart disease in terms of the coronary atherosclerosis and plaque buildup? So here's a picture of the heart muscle, and you can go to the next couple of clicks that's going to describe it. So here you have the heart muscle sitting in the middle of the chest. And as you can see, the muscle is attached to larger blood vessels that are in red and blue, the big ones. And those are the blood vessels that pump blood out of the heart and to the heart, to the lungs, and back from the lungs. So on the outside of that muscle are arteries that supply the muscle with blood flow. The heart muscle doesn't get its blood from inside. It comes from these other arteries on the outside. These are your coronary arteries. And these are arteries that we talk about that have become filled with plaque and diseased and require either bypass or stents. You go on the next slide. So we take one of these arteries and we cut them. You can see that it's basically a pipe. And inside that pipe, sludge builds up. And Stu, you can keep clipping it as well. So you get deposition of cholesterol as well as white blood cells that go into the lining of the blood vessel wall. And this gradually restricts flow through the vessel. And at times, the plaque itself can rupture and cause the contents of the plaque spill out into the bloodstream itself. And that causes a blood clot to form. When the blood clot forms, it may cause a complete obstruction or partial obstruction. And that's what we talk about when we talk about with heart attacks or acute coronary syndromes. So if you look at it from another angle, basically fat and cholesterol deposits into the blood vessel wall. And you can keep going, Stu. And this is caused by a combination of high cholesterol as well as endothelial injury and inflammation. That injury can be from wall stress or shear stress, but you need those three components in order for the fat and the plaque to build up in the blood vessel wall. If you just have high cholesterol by itself without anything else, it's not going to cause a problem, but you have to have the cholesterol and the inflammation, which is why our traditional risk factors of heart disease are high cholesterol, hypertension, diabetes, family history of heart disease, and smoking, tobacco, usually regular tobacco, but also inhaled non-tobacco and nicotine. So other risk factors for heart disease, besides the main factor we talk about, are things like bad gum disease, periodontal disease. And this is caused by the bacterial pathogens getting into the circulation of the blood throughout the body, and then causing that vascular injury and stress. When that vascular injury occurs, you get more of the pathogens increasing inflammation and allowing any cholesterol, usually lipoprotein B, diving into the blood vessel wall, causing plaque buildup with time. You go to the next slide. And other risk factors like sleep apnea, which we don't usually associate with heart disease, but if you think about all the different things that cause sleep apnea, you can see how it can lead to heart disease, and you can clip through. So with sleep apnea, you have a poor sleep pattern, and this leads to reduced restorative sleep time. What I mean by that is you need a certain number of hours in REM sleep or deep sleep, stage 4 sleep, in order for your batteries to get charged. If you don't have those periods of REM sleep because of sleep apnea, then you have less restorative sleep. This increases your stress hormones, which are your catecholamines, your cortisol. It can increase chances of arrhythmias, electrical problems of the heart. It can lead to increased chances of recurrent heart attacks. It can affect your blood pressure to the point that medications that we use for blood pressure may not be as effective in controlling blood pressure because the underlying problem of sleep apnea is still there. It can also worsen congestive heart failure and diabetes. And lastly, the one thing which is not heart disease, but the one thing that's been directly associated with is an increased chance of stroke. So all these different things can increase your chance of heart disease, all from sleep apnea, which is one of the more underdiagnosed medical problems that we find very prevalent in our society. So other surprising risk factors are infections. I highlight just 3 of them here because these are probably the 3 more well-known viruses that can lead to heart problems. Influenza, Coxsackie, and now SARS-CoV-2, also known as COVID-19. So these viruses can do 2 things. They can cause direct damage to the heart muscle by directly attacking the muscle of the heart, causing what we call myocarditis, which is quite common with COVID-19, as well as Coxsackie. But other effects can occur, such as with influenza, where it causes an inflammatory cascade. So you get inflammation occurring throughout the body, and specifically the arteries throughout the body and the arteries of the heart, which can lead to plaque buildup. And unfortunately, if there is plaque buildup already there, the inflammation can cause that plaque to rupture and cause that blood clot that I was talking about earlier, which can lead to a heart attack. And you can clip one more time. So there are also different types of abnormal cholesterol, unusual dyslipidemias, we call them. They're usually familial, and they're usually the patients who have a family history of bad heart disease, but yet their cholesterol numbers are fine. And you can clip that as well. So if you look at people who have a family history of heart disease, but their cholesterol numbers are okay, it's important to dig a little deeper and to look for different types of cholesterol subtypes, what we call apolipoproteins or lipoproteins. So it's lipoprotein little a, There's apolipoprotein E and apolipoprotein B. And these cause other types of cholesterol deposition in the muscle of the heart and in the fat tissue. One of my favorite slides, because I hear this all the time. Stress. Is stress a risk factor for heart disease? The answer is yes. Is it a major risk factor? No, but it can definitely increase risk. And this is all types of stress. So you can have stress from loud noises. If you're chronically working in an environment, construction environment, or you're working on trains as a conductor, or you're at an airport working on planes, the stress of that loud noise can not only affect obviously your eardrums, but it can affect you as an individual, causing increased stress hormones. And again, those stress hormones can increase vascular inflammation, thereby increasing the likelihood of getting heart disease. Other types of stress include stressful jobs, stressful physiologic problems where your body just makes too much cortisol. So certain adrenal problems, adrenal glands sit on top of the kidneys, and they're the ones that make your stress hormones. And I'll talk more about that in the next slide. So the stress response system. Your brain makes something called ACTH, or adrenocorticotropic hormone, and this sends a signal to your adrenal gland, which, like I said, sit on top of the kidneys, and then your adrenal glands spew out tons of adrenaline and cortisol. This thereby increases your heart rate. It makes the liver make more sugar, and it increases digestive systems, as well as increasing your blood pressure. You can click through again. So autoimmune diseases will increase your stress hormones, as well as increasing vascular inflammation. I think there might be one more click on this, as well as chronic kidney diseases can also cause increased cortisol levels and vascular inflammation. So what about medications? Can medications increase your chance for heart disease? Absolutely. Medications like stimulants that we use for some psychiatric illnesses or ADHD, such as methylphenidate, non-steroidals, anti-inflammatories, which are over-the-counter non-prescription medications like Advil, Aleve, Motrin, ibuprofen. All of these will increase some degree of vascular inflammation and increase your blood pressure. The question is, in the short term, is it a big deal? And the answer is no. In the short term, if you don't have significant heart disease, taking these medications to alleviate pain, inflammation, and discomfort are okay. In the long term, though, popping, Motrin, 4 or 5 times a day for several months or several years will certainly increase your risk for heart disease. And then other medications, which we think are totally safe because they're herbal, actually increase your risk significantly. So some herbal remedies that contain a substance called ephedra, and particularly an herbal remedy called mawang, is very well known to increase vascular inflammation and increase chance of heart disease. Licorice, and this is natural licorice, black licorice, not licorice that you find in the United States because it's outlawed, can increase your chance of arrhythmias by affecting certain electron channels in the heart muscle, but can also lead to increased blood pressure. And of course, dietary aids or dietary stimulants with excessive amounts of caffeine built into them. Right? So the idea of giving someone a dietary supplement to boost their metabolism by increasing the amounts of caffeine intake may sound all fine and well and good, and you're burning fat while you're asleep. What's happening, though, is you're causing your blood pressure to go up, you're causing your heart rate to go up, and you're causing an undue stressor to the heart. And then one of the things that are is very prevalent, which is a mixture of different disorders, is metabolic syndrome. Metabolic syndrome is a combination of 5 different criteria, and you have to have 3 out of the 5 for you to have the diagnosis of metabolic syndrome. The important thing about metabolic syndrome is we treat it by lifestyle changes, not necessarily medications. So what are the 5 criteria? Well, you can see your large waistline, more than 35 inches in women, 40 inches in men. High triglycerides, more than 150 milligram per deciliter. Having a low HDL. HDL is the good, healthy cholesterol. So if you have a low amount of that because of lack of physical activity, that's going to increase your risk for heart disease. And impaired insulin resistance or prediabetes. If your blood sugars are higher than 100, fasting blood sugars, or if your hemoglobin A1C is greater than 5.7%, then you have pre-diabetes. Now that is before you are diabetic. So if you have these things, pre-diabetes, along with these other factors, then that increases your risk for heart disease, as well as hypertension, which is the last bullet point here. If your blood pressure is not well controlled, that, in addition to the other things, constitute the metabolic syndrome. Metabolic syndrome is a syndrome of lifestyle and is significantly improved and reduced by changing lifestyle. So more exercise, increasing your whole food, plant-based diet, and watching your saturated fats. Does that mean that you have to become a vegan and be totally plant-based? No, it's not an all or nothing situation. The more you can shift your diet towards less cholesterol, more plant-based foods, less red meat, and certainly less processed meats, which is probably the biggest culprit, the more you can shift your diet into the healthier direction, then the better off you are in reducing your risk. So it was a very brief overview about some of the surprising factors. There were a bunch of other risk factors that I came across that seem to be a little too rare and too uncommon for it to be part of a robust conversation. I thought it would be better off if we just kind of talked about these risk factors and these surprising risk factors in terms of reducing risk. I think there's a bigger impact. I always tell patients when they're looking at changing lifestyle or making changes to reduce their risk, the important thing is to go for the low-hanging fruit first, and then tweak things later on. So by low-hanging fruit, I mean things like the obvious things. If you know that you're drinking way too much soda and you're a big fan of the late-night cookies and treats, and dessert is always part of every meal, then you know what the easy, low-hanging fruit, is, and you know how to best reduce your risk for heart disease by attacking those things. Attacking those things will make a big difference in that person's risk for heart disease than trying to switch from, white rice to brown rice, or, pasta to whole wheat pasta. So with that said, any questions I'd love to answer, or maybe anything I went over too quickly, which I sometimes do because I had a second cup of coffee. I'm more than happy to go over things again or discuss things in more detail.
Okay, we're just waiting for questions. If you have any questions, you could enter them in the Q&A feature located at the bottom of your screen. Okay, we have one question. If your long-time sleep hours have been between 5 and 6 hours a day since you were a teenager, can that cause a problem for you as a senior?
So good question. We usually say, 6 hours of sleep is probably the target. If you're off by an hour or so, maybe not so bad. But if you find that you're getting only 4 hours of sleep, or if you're getting even 7, 8 hours of sleep, but that sleep is very disrupted, then that can be a problem. So it's not so much the number of hours, it's more so the amount of time spent in deep sleep. So if you find that you're, exhausted during the day, and the hallmark things that we look for sleep apnea is you find that you can nap easily if you're not mentally engaged in something. If you find that sometimes if you're at a red light and you find you're nodding off, that's a big red flag. If you find that you're waking up in the morning with a headache, is also an alarm. If you find that you wake up and you feel like you haven't, you're not well rested. And then of course the obvious ones are if your spouse says that, it sounds like a freight train while you're sleeping, or even worse, it sounds like you stop breathing in the middle of the night and they have to literally nudge you to get you to start breathing again. Those are the big telltale signs and the red flags that we hear that tell us, that prompt us to have a patient go for a sleep study to figure out if their sleep patterns are truly affected.
Next question, what about low-dose aspirin?
So low-dose aspirin for primary prevention is recommended if you have 1 or 2 risk factors for heart disease and you're under the age of 70. When I say primary prevention, I mean that you haven't had a cardiovascular event previously. So those events would be if you've had a stent, if you've had a heart attack, if you've had bypass, or if you've had a stroke or peripheral vascular disease. So if you've had a stent in your legs or bypass in your legs because of poor blood flow, that then becomes secondary prevention. And if you have secondary prevention, you should be on low dose aspirin long term. But if you haven't had any of those, then the benefit of taking aspirin is only indicated if you're under the age of 70 and you have diabetes and 1 other risk factor, or you have 2 other significant risk factors for heart disease. Otherwise, taking aspirin outside that range may increase your chance of bleeding. And that's also with the caveat that you don't have an increased risk of bleeding. So if you're diabetic and you have high blood pressure and you're 55 years of age, then the indication would be to take a baby aspirin a day. However, if you also have a history of having a bleeding ulcer or a gastric ulcer or diverticulosis or any kind of bleeding history, then no, I would not recommend taking aspirin, because it's all about, everything we do in cardiology is risks and benefits, right? So if the risks of taking something is up here and the benefit is down here, then you shouldn't be doing it. But if the risk is up here and the benefit now is up here because you've had other issues, then yes, the risks outweigh the benefit, or the benefits outweigh the risks, excuse me.
Next question, should there be 2 different BMIs, one for men and one for women, since men and women are obviously differently built?
So good question. The BMI is basically your body mass indicator, body mass index, excuse me. It is not a function of overall risk. It has to do with height versus weight, and that's all it is. So if you're a height versus weight, so it's an index, it's not a specific number. If your height versus weight comes out to, between 15 and 19, then that's considered your ideal, BMI. Between 19 and 25, between 19 and 25, you're considered to be overweight. More than 25 to 30 is overweight. More than 30 is obese. More than 40 is morbidly obese. That number is just based on your height versus weight average. If you want to look into body fat percentage, then yes, that definitely has an effect on male or female. The BMI, we haven't really come to having 2 different numbers or 2 different categories for male versus female. But I think in general, you need to take everything into context, right? So if you have somebody who has a certain stature or have somebody who has a certain body habits, pear-shaped versus apple-shaped, all of that plays a role. But the waist circumference, that difference exists because men tend to have more visceral fat, so belly fat, whereas women tend to have more adiposity fat, so fat or subcutaneous fat that is diffusely on the body, particularly thighs and arms with women, whereas men tend to have more of the belly fat. The problem with the belly fat and the visceral fat, both for men and women, is that visceral fat becomes metabolically active. The adipose tissue, which is fat tissue, starts to actually secrete chemical signals or hormones. And some of them actually affect how well our body handles our sex hormones and how well our body makes more or less of estrogen and testosterone. So the more visceral fat you have, the more estrogen your body's going to make. In addition to that, the more insulin resistance your body's going to start to develop, which is why metabolic syndrome is so significant, because when you have that extra visceral fat, you're likely to having insulin resistance, and prediabetes or diabetes becomes much higher. There are some other there's some other medical disorders that can occur because of increased visceral fat. And one of them is non-Hodgkin's lymphoma. So people who have higher degrees of visceral fat or belly fat are a higher risk for lymphoma compared to somebody without that, with all other variables being the same.
Okay, another question here is, what is a good number for the bad cholesterol?
So a good number for the bad cholesterol, which is the LDL, or I would say a better way of looking at it is not just looking at the LDL, but a simple, easy way of doing it, which a lot of cardiology experts or authorities are recommending now, is looking at your non-HDL. We know that HDL is the good, healthy cholesterol. So if you take your total cholesterol number and subtract out the HDL, you're left with the non-HDL. So if my cholesterol was 215 and my HDL was 65, my non-HDL would be about 150. Ideally, you want that non-HDL to be 130 or less. That's ideal. We usually do not intervene pharmacologically. In other words, we don't give medications unless that non-HDL is 160 or greater. That's for the non-HDL. For the LDL, the rule of thumb is 130 is okay. We like to get it down to less than 100. So between 100 and 130, it's, lifestyle. If you can't do it with lifestyle, then it's medications. One of the things that you should be asking your doctor to do is looking at your 10-year ASCVD risk. That is your 10-year likelihood of having an atherosclerotic cardiovascular disease event. And that number is a calculation that we plug into a calculator based on your age, your gender, your ethnicity, smoking history, diabetes, blood pressure, and then your good cholesterol and your total cholesterol and your bad cholesterol. And that number gives us a percentage. Ideally, you want that number to be less than 5%. If that number is between 5 and 8%, you're considered intermediate risk. More than 8%, you're considered higher risk. And at that point, cholesterol medications, specifically statin medications, are recommended. And yes, statin medications have their potential side effects, but for the most part, those side effects are not that common compared to what you hear about amongst, the lay persons discussing it. It's only around 20% likely that you're going to get an adverse effect. And most time that adverse effect is reversible. In other words, if I put you on a cholesterol medicine and you may get muscle aches, and if you get the muscle aches, we stop the medicine, it goes away, and we try a different medication. So it's not as bad as a lot of people tend to think cholesterol medications are. Of course, if you can get your cholesterol numbers down to good levels without medication, that's better. I would love that. But to do that means becoming more and more plant-based and shifting your diet towards more whole foods and not processed foods.
Okay. We have one more question here. In terms of sleep, can I split 7 hours of sleep into 5 at night and 2 in the afternoon?
So good question. It all depends on how long it takes you to get into that REM sleep. If you can get 4 hours of REM sleep in that 5-hour period, and you can get an hour and a half of REM sleep during that 2-hour period, then you may be okay. But that 2-hour period, if it's not getting you into deep sleep, into restorative sleep, then that 2-hour period is just not helpful. I always use the analogy of plugging your cell phone in at night. If I use my battery charger, I don't have it here, but if I use my battery charger, I plug my phone in, and the plug is half in, half out, either here or at the outlet. And I leave it there overnight, and I grab it the next morning to go to work, and I look down and it says, 12% battery life. How is that possible? It's been charging all night. It's possible because I thought it was charging, but it wasn't charging. I was only getting a little trickle here and there, and therefore it didn't charge. Same thing with sleep apnea. If you have disruptive sleep and you're not getting full restorative stage 4 REM sleep, then you're much more likely to have low batteries and running around on steam, or running around on fumes, excuse me, and having increased catecholamine levels and stress levels and blood pressure and all sorts of other issues.
Okay, we have another question now. It's, if you take Repatha for high cholesterol and you plan on getting pregnant in the next 6 months, what would you suggest to do?
So good question. I'm actually, Repatha is not indicated or is not recommended during pregnancy as far as I know. If you were to stop the Repatha for, a month before you start getting pregnant or trying to get pregnant, and then not take it during pregnancy and then go back on it after, lactation, then you're without Repatha for, a year and a half. That isn't necessarily such a bad thing. The big issue with cholesterol lowering is the long-term risk. Same thing with high blood pressure. It's a long-term gain. So if your blood pressure is up, to 150 for a couple of days, 150 for a couple of days, it's not going to significantly increase your risk for anything really, which is different than if your blood pressure is above 220 or 230. That's a whole different story. But getting back to cholesterol, if your cholesterol goes from having a total cholesterol of 190 to going up to let's say 250 or 260 for a year, I don't think you're substantially increasing your risk. And I think the benefit of having less worry about being pregnant and bringing a child into the world, I think that benefit outweighs the small potential risk of having a higher cholesterol for a year and a half, as far as that's concerned. But I would also recommend, obviously, talk to your doctor about it. And this whole conversation is moot if you're a male and you're trying to get pregnant with your spouse. You can still take your Repatha and not worry about it affecting your spouse becoming pregnant.
Another question is, what can we do to get more productive sleep?
So great question. Things you can do, first off, is weight loss. Weight loss has a big impact on the soft tissue around our airway and how that soft tissue can put undue pressure on the airway while you're sleeping. In the interim, while you're trying to lose weight, things you can do is make sure you avoid alcohol before you go to bed. Alcohol is one of the things that, I sleep great when I drink, but that sleep is not, restorative. There's a lot more apnea that's caused by alcohol than you realize. You can just ask your spouse, if you've had a couple of cocktails in the evening and then go to sleep, they're going to complain that you snored so much more that night than you did on prior nights. So alcohol before bed is definitely going to worsen apnea. Weight loss is important. Exercise is great. I would say do a couple of hours, if not longer, before you go to sleep. You don't want to exercise right before you go to sleep because that can disrupt your sleep patterns. But having a good exercise routine during the day is going to help you sleep better at night. Obviously, no caffeine for 7 hours before sleep time. And if you find that you do have apnea, if you find that you do get complaints from your spouse about your snoring habits and about not breathing, one of the things I recommend patients to do is get yourself a t-shirt with a pocket in the front, wear it backwards so the pocket is now in your back, and get a lacrosse ball or a hard ball of sorts. Tennis balls are a little softer, but a lacrosse ball works great. Put it in the pocket so that way it forces you to not sleep on your back and you constantly turn to your side. Even though you think that you're a side sleeper, and I always sleep on my side, we all move while we're sleeping. So that lacrosse ball is going to help to encourage you to get off your back and alleviate some of that extra pressure on your airway when you're sleeping.
Another
and
question.
Also, breathe right strips work as well.
Sorry. Another question here. If your cholesterol levels are good, but triglyceride level is 180, does that increase the risk for heart disease?
It does, but it's borderline. Having a triglyceride of less than 200, between 150 and 200 is considered borderline. It's not considered, high. And that's something that is very much impacted by lifestyle. So diet and exercise have a tremendous impact on triglycerides compared to the LDL bad cholesterol. So I would say try and tweak your diet some more, try and improve that exercise habit a little more. But it's not going to significantly increase your risk. Is it going to increase your risk? Yeah, marginally, but not significant that I would say you need to start, taking more drugs for that.
Okay. What is the optimum blood pressure for someone 75 years of age plus?
So optimum is less than 130 over 80. With that said, if you have diabetes or kidney problems, you may want to shoot for less than 120 over 70. Now you're going to say, Dr. Shnuda, that's absurd. Those are such crazy low numbers. They are, but that's what the data shows us in terms of, we look at population health and research trials. That's what's going to help to reduce chance of heart failure, stroke, and worsening kidney problems. If your blood pressure, though, is 142 over 82 and you're in your 70s and your doctor prescribes a medication to lower your blood pressure and your blood pressure drops down to the hundreds and you're symptomatic, then sometimes we have to just tolerate some degree of slightly higher blood pressure for certain individuals. That's not across the board. That's for certain individuals that are very sensitive to medication or who have something like an orthostatic hypotension where their blood pressure drops easily when they go from sitting to standing. But usually, yeah, less than 130/80 is the ideal.
Okay, that seems to be it. Let's see if we have any other questions. Oh, one more. What are some things someone can do today to help lower blood pressure besides using medication?
Great question. So there's something called the DASH diet, DASH. It stands for Dietary Approaches to Stop Hypertension. A quick, easy Google search, basically type in DASH dash diet and PDF as the the document, and it'll bring you to the NIH website with a nice PDF printout about dietary changes that you can make to lower blood pressure. And a lot of it is similar to what I talked about, which is whole food, more plant-based diet. Definitely no processed meats because they're notoriously filled with sodium. No canned foods or canned goods because also notoriously loaded with sodium. And if you do all that and you find your blood pressure still on the high side and you want to be all natural, one of the things you can try doing is beet juice extract. So 6 to 8 ounces of beet juice a day has been shown in clinical studies to lower blood pressure to the same degree as some antihypertensive medications. So beet juice can lower your blood pressure just as much as a blood pressure medication without taking blood pressure medication. The only side effect is you have to like the taste of beet juice. If you don't like the taste of beet juice, you might want to try just taking the medication. But beet juice extract works great for lowering blood pressure. And of course, avoiding sodium, both in processed foods and canned foods, processed meats. Every time we purchase something, there's a nutrition facts on the side, and we all make a habit of looking at it, and we're looking at what is the caloric amount, what is the amount of saturated fat. Oh my God, there's this much fat, there's this many grams of sugar. Rarely do we look at the sodium, but sodium is definitely there. And I would say sodium is probably one of the more important things to look at, especially if you have high blood pressure. Your daily allowance for sodium should be less than 2,500 milligrams a day. If you have high blood pressure, or if blood pressure is a problem, then you want to shoot for less than 2,000 milligrams of sodium a day. That number you may think is quite high, especially if a side serving of corn is 300 milligrams. But if you think about that, that's just one side serving of your entire meal out of 3 or 4 meals you have in a day. So 300 milligrams is actually quite a lot for a side serving of corn. And in fact, quick story, I was told my wife to go to the supermarket to get canned artichoke. She wanted to make artichoke dip. I'm going through the canned section, and I come across the corn. And one corn, this is both ShopRite brand. One has a big, huge blue label, no added sodium, and the other is just plain labeled, nothing special about it. So I'm curious. I look at it. Sure enough, the regular corn is 337 milligrams of sodium per serving. So I'm curious how much less is the low added or less added sodium. It was 57 milligrams of sodium. So the difference was 5-fold in terms of how much sodium between the two. Obviously, if you get corn on the cob, there's no sodium at all. So when you make your your grocery shopping or you do your grocery shopping, I would say take the extra 10 seconds to just look at the container and see how much sodium is really in this.
Okay, another question. What is the best time to take blood pressure medication, in the morning or at night?
Great question. And I would say it depends on you as an individual and where your blood pressure tends to be higher. It also depends on the medication you're taking. Most medications I tell patients to take at night because you want it to control that morning blood pressure spike that oftentimes we get as our catecholamines and stress hormones turn on when we wake up. However, with that said, if you're taking a diuretic as a blood pressure medicine, so hydrochlorothiazide, triamterene, chlorothalidone, or any medication that has those diuretics into it, like lisinopril hydrochlorothiazide or irbesartan hydrochlorothiazide, those medications you want to take in the morning because they are a diuretic effect and they're going to have that increase in urine production on the kidneys. So you don't want to be taking those medications at night because you're going to have to wake up in the middle of the night to go to the bathroom a couple of times. So you're better off if there's a diuretic in your medication, take it in the morning so that way you can go to the bathroom while you're awake and not have to get up in the middle of the night to go to the bathroom. But the rest of the medications, If it's amlodipine by itself or biastolic by itself, I would say take in the evening. Some of the medications are 24-hour medications or long-acting medications, and it may not make a difference if you take it in the morning or night. I hope that answers the question okay.
Okay, another question here about salt. How many milligrams is a pinch of salt?
Good question. I would have to guess. I'm going to guess it's about 50 milligrams for a pinch. I could be wrong. I'm sure if we, Google, we can find out what a teaspoon is and then kind of extrapolate, from there. In fact, I'll tell you momentarily. Pinch of salt, sodium level. So 1 teaspoon is about 2,300 milligrams of sodium. A pinch, which is about 1/8 of a teaspoon, is about 250 to 300 milligrams of sodium. So there you go. So something I learned just now. Yeah, a teaspoon of sodium, a teaspoon of salt is quite a bit of sodium. So a pinch is just under 300 milligrams, which is not a trivial amount. So even though we do a little pinch in the water, when we're boiling our pasta, you're adding 300 milligrams, but that's a whole pot of pasta, and you're going to have a small serving of that pasta, hopefully not a whole pot. So therefore, you're going to have less sodium intake from that.
Yeah, I think we have one more question. When is I think you answered this right. When is the best time to take cholesterol medication?
Cholesterol medication is usually the best time or at night, particularly with the older generation cholesterol medications. So your pravastatin, simvastatin, and even atorvastatin usually take at night. Rosuvastatin, which is generic Crestor, it should not matter to take it in the morning or night. The reason why it's important to take these cholesterol medications at night is because the liver tends to make and package cholesterol while you're sleeping. So that lipogenesis or that lipid compartmentalizing into LDL and HDL and all that stuff, that usually occurs at night. So taking it before you go to bed is probably the best time for cholesterol medication.
Okay. Another question. I have several risk factors for plaque buildup. How can I find out if my arteries have been building up plaque?
So one of the best ways to find that out, I would say even before finding it out, I would say if you're worried about plaque buildup and you have several risk factors, then treat yourself. I would just go on the cholesterol medication. And you're going to say, but doc, that's crazy. If I don't have to, why should I? Because more than likely, given those risk factors, you probably do have to. But if you want to know if there's cholesterol buildup or not, there's a simple test called a CT coronary calcium score. Basically, that's just a CAT scan of the heart, looking for coronary calcium and plaque buildup. A lot of insurance companies will not cover that because they find that it's either experimental or it doesn't impact overall care. But I know that some of the independent radiology centers in the area, like Zwanger Passeri, and I'm not employed by them, I don't get any kind of kickback from them, but I just know from sending patients to different places that Zwanger will do it for $100 out of pocket. You pay them, they do a quick CAT scan. There's no IV, there's no contrast, there's no medications, and they can tell you if there's coronary calcium or not. And that may guide you, say, oh my gosh, there is coronary calcium, which is a sign of plaque buildup. Because when you get plaque buildup, the body tries to stabilize that plaque by calcifying and hardening it so it doesn't become vulnerable and break open. So that coronary calcium is reflective of coronary atherosclerosis and plaque, which is also why we call it hardening of the arteries because of the calcification. So if that's there, then I certainly wouldn't even think about not. I would definitely take cholesterol medication. I would take a statin medication to prevent that plaque from getting any worse.
Okay, that seems to be all the questions we have. Dr. Shenouda, thank you very much for your presentation. If anyone has questions that they think of after the webinar, you can always email them to us at matherhospital@northwell.edu, and we will pass them along to Dr. Shenouda. Once you exit the webinar, you'll be directed to complete a brief survey. If you could please complete that survey, your feedback is extremely important to us and helps us plan our future webinars. If you'd like to view other HealthyU webinars that we've presented, you can find them all posted at www.matherhospital.org/HealthyU. Again, thank you for joining us today and enjoy the rest of your day.
Thanks all. Stay healthy.